Okay, everyone, good morning. I am calling to order the April 23rd Finance Planning and Investment Committee meeting. Is that a gavel in? Before I get started, I wanted to say a big thank you, on behalf of the board and everyone here and the whole JPS team, and a big congratulations to the hospital towers groundbreaking ceremony. So that was a great day and a long time coming, and a huge success. And I just wanted to take a moment to thank everyone that's been involved, and it's a huge win and moving forward for those in Tarrant County. So thank you guys again. So today we've got no citizens wishing to address a committee. So moving on to item number 3. I would like to get an approval of the meeting minutes from March 26th. I've got a first from Dorothy. Second. We have a second from Reverend. All in favor? Aye. Any opposed? Okay. As far as reports and updates, there are no reports, so we are going to move on to our CFO update. Kim, this is going to be to consider to approve the March unaudited financials. And just for the record, this is our fiscal year ends in September, so this reflects the first 6 months of the JPS operation. So go ahead, Kim.
All right, good morning, everybody. Just a couple updates. We had our debt ratings from Fitch and S&P reaffirmed. We had Fitch and KBRA in January, but we are trying to get the cycle onto the spring. So Fitch and S&P did reaffirm our AA and stable ratings. KBRA, which has given us a AAA and stable, will give us their final at the end of the month. So I think that's great news considering the headwinds that healthcare is facing and the great work that leaders have been doing here. So just wanted to share that with the group. I also wanted to share that with our investment policy, for those of you who don't know, we're subject to the Public Funds Investment Act, and I had Hilltop, who's our investment advisors, review it to make sure it's still compliant with PFIA, or Public Funds Investment Act, and we are, because there was nothing changed by the Texas legislature last year. So we will be reviewing the policy for opportunity potentially to expand our investments and our ability, but the first on the table was to make sure we were still compliant with the Investment Act. So I just wanted to share that with everybody. All right, well, let's dive into March. As we look at the first 6 months that Dustin had mentioned, our performance has been steady. As you can see, this is the red line on this graph is budget, the green is last year, and the blue is the current year. This is net income or bottom line performance. And so you'll see that we continue to improve performance in the blue bars. You might say, why is green so high last year? Well, we had some DISH one-time settlements as well as some uncompensated care settlements that came in. So comparable, if we took those out, we'd be relatively close to where we were last year at this time. So as we move forward and we know that there's operational pressures hitting healthcare across the board, and we're also going into the most intensive capital spending period for our master facility plan. I just want to show you that we have this steady navigation going on and what we've seen in the last 6 months. And as we know, we're doing a forward look, it's forward thinking, what can we do, what can we anticipate for the known and maybe the unknown with everything that's happening at local, state, and federal level. I will note on here that the month-to-date financial performance, and I'll go over it in more detail, was not at budget. That was primarily driven by unrealized gains and investments, and I'll go over that in more detail in just a moment. Similar to how we build our budget, we start with volumes. Volumes drive our staffing needs, the revenue we see in the organization. These two graphs, again, the same format, red line is budget, green last year, blue is this year. What we see here on the left side are inpatient discharges. You'll see for the month of March that we've been below budget for the month, but when you go over to observation patient cases, which are people in the hospital, but they don't qualify for the care as an inpatient, but they're still in a bed, and we're still taking care of them, and they're pretty resource intensive. Your first day is always intensive when you come into the hospital. you can see for March that our blue bar is above budget. When we put those two together, our volumes in the hospital taking care of patients is slightly above budget, actually. And so the volume is there, the mix of the volume between inpatient and observation is just the change that we're seeing. So we are still very full, we are cohorting, which means putting 2 patients in a room when necessary for the organization. As well as then how this translates, I'm gonna read on the right side first for emergency and urgent care services. You'll see the bottom light green is urgent care, the dark green is the main or the medical ED, and then you'll see some smaller numbers up there on the top. Above the medical is the PEC, and then we have the OB, GYN triage. These are, except for urgent care, these are all considered emergency room visits, billed that way for the hospital. You will see shortly that we are slightly under, we are under in the ED, particularly in the inpatient, which then directly correlates to our volumes being down on the inpatient discharge side. It also will correlate when we see the surgery variances. On the left side, you see surgery, endo, and interventional radiology, which is IR. These are all procedural spaces, so you'll see it build up inpatient and outpatient. And then you have Jessica, the outpatient surgery center in Arlington. What does this mean from a variance perspective? This is our volume highlights page. I will have to tell you the very top line is our patient encounters. We are right on budget for patient encounters. We're seeing a similar amount of patients in the community, just a different mix of patients across the spectrum. The second box you see, you'll see the acute discharges where I mentioned that they were down. We are also down from last year, but again, with observation together, we are on target. When we go down to the third box, we see surgery cases, and we just see pure surgery, and then we see all the procedural together. And that's pretty important because, as you may recall, the last few months of the calendar year, we were replacing the air handling systems in the OR, and so that required us to move patients around into different environments, sterile and appropriate, to see the cases. We also do know in March that we had a few orthopods on vacation, and so that does account for some of that volume that we do see declined there. The emergency room visits, I would take you, you'll see that we had a significant drop in emergency room visits. Again, nothing in the market has suggested a why. However, we do see that the psychiatric visits are starting to pull away from the main ED and go to the psychiatric ED, which is great because then we can focus on the population and the care they need. Together, they're still down on the inpatient side, but up on the outpatient side. When they're up on the outpatient side, many of those patients go into that observation status or that outpatient status. And so just kind of sharing that along the way. The other thing that we are seeing is the inpatient. We are having a longer length of stay right now, and primarily we have some long lengths of stays for patients who are just hard to discharge. How do you get them to a care facility or back to home as fast as possible? Sometimes they don't have a caregiver at home, and so we work through, as appropriate, our connection program for them, other services. Do they just need DME to go home? We're working through a lot of initiatives on there. Dr. Assad, Dr. Peeler, and Devin Armstrong, who's case management, have a great plan moving forward about how we can look at getting patients to the right setting for their care versus having them just stay in the hospital. And the bottom line, and the bottom of here, you see the clinic visits altogether, roughly close to budget. Again, primary care, a little bit down for the month. We did see some vacations that did occur in March, not excessive, but some providers out of the office. And so, however, the good thing was their worked RVUs were on target, which means worked RVU is the acuity of the visit, basically, or how severe the visit is. So we saw that a little up for the month.
Mental state, where you have those patients who are staying beyond what we like for them to stay. Do we do any counseling or talking with them to find out if there's someone to discharge them to when they come in?
We do. That's part of their care planning. So we have case management that really tries to get them home, get them with a family member, get them with someone that if they need care. And sometimes they may just be able to go home. Sometimes they're homeless. Sometimes they can't go back to the shelter because they can't meet the average daily living requirements in order to live in the shelter. So they sometimes come in with a complication and they can't go back because they can't live on their own. They need assistance, so could we discharge them with home care? We also have a challenge with the jail. The jail, when we get jail patients in, we can't always get them back to the jail because the jail is full. And so sometimes we have jail patients here for a while too. But we do have a case management team that really works on how to get these patients home.
Yeah, I was just thinking because, another area maybe I need to talk to case management about this, is that, I was just thinking that the pastoral group that I meet with, it might be another route to talk to them. You know, because you might have pastors who have members who can help with that, you know, when they discharge to get, maybe somebody in the church can go and be with them. So I'll bring that up at our pastor's meeting.
Okay, that sounds great, yeah.
Yeah.
Thank you.
Thank you, thank you.
And, Ken, what I see with the throughput there, we're dealing with, 5.7, and it's now 6 days length of stay. From a math perspective, for me, right, that's 5% above plan. So, which reduced the capacity. So for a 500-bed hospital, that's a 25-bed, effectively unavailable due to longer stay. That can convert to somewhere between $37 and $50 million in annual revenue opportunity loss. So whatever the investment that we need to make to get them out is that opportunity that we need to be focusing on. So that, because if we see that, I'm not sure what the net collection would be.
So DT, you're right on needing to find a way to get them home. We're working on remote patient monitoring at home also. We're working out how do we get them to their primary, to Reverend's point, how do we connect them with their church or their other resources in the community? We have resources, but always open to hearing and learning about more resources that are available. We're also partnering with some of the long-term care facilities to say, can we just have a certain number of beds so that we have those available for these patients? Because it's less expensive to put them in those beds to free up an acute bed.
Right. But, when we have a capacity limit because we need to build a new hospital, right? But if we see between $37 and $50 million sitting there potentially, I think the decision can be made by operation people a lot quicker or a lot more clear, right? Because you trade some expense to get more opportunity or something like that. Because, but that's just
Absolutely, absolutely. Other questions about length of stay?
Kim, question, I mean, how do we compare like year over year? I see where the target would be 5.7, and year-to-date we're at 6, is that right?
Talking about length of stay?
Yes, but I'm still talking about the length of stay.
Absolutely, let me get to the number just so I'm looking at the same number. So the prior year is 5.6, the prior year-to-date is 5.68, if you go all the way over to the right. And
Okay.
so again, as we look at the case mix index, the severity of the patients hasn't really changed much. It's the complexity of the patients that has continued to change and how to get them to a place where they can not come back if they don't need to, right? That's one of our goals is how do we get them to not be readmitted? How do we make sure they can
Sure.
go to a place? And I think for some of the population that we serve, they don't have family or they have family who don't want to be involved for whatever reason. And so that's a challenge. And repatriating is really tough because you usually have to have a person on the other end to accept them. You can have a facility on the other end too, but you have to make sure that you have that all arranged. And so repatriation is also part of the process, but it's discerned.
Okay, thank you.
I have a question on urgent care. It looks like that, not urgent care, observation, that number is continuing to go up. Is there anything we're looking at to kind of reduce that? Because that's not a lot of money when you're sitting over in observation in an inpatient bed. So is there any review of something that we could look at proactive on some of our patients. I don't understand why observation is going up, that's number one. And I don't know how long they're staying in observation. But I do know that it is not one of those that's financially feasible. We get less money, it's like an outpatient bed. So I think some focus on how we can work that, who's admitting them to, who takes care of those folks. So those are the kind of questions that I think we should be looking at.
When I see discharge are down 5%, surgery up 9%, and the case mix is flat, it's kind of indication that we may be understaffed or we're not coding correctly. We're too conservative, because if you put them in observation when they could have been, they're actually inside, they occupy a bed, right? So they technically could be inpatient if we spend more time and look at it. So I'm more concerned about is that.
So I will tell you that when a patient comes into the hospital from the ED, it's because they are not safe to go home.
Right.
We work really closely with case management and our utilization team to determine, do they meet criteria to be a full admission? If so, wonderful. You know, if not, they'll go into observation status. That observation number is high, and there's a lot of reasons for that, but one project that we're working on with Dr. Assad and her team is, can we find a subset of those patients who would do okay with close follow-up? So the ED is making relationships with the family health centers and the clinics and the cardiologists and the specialists. And, you know, if at all possible, can we set up follow-up within 24 hours or 48 hours that they can go home knowing that someone will see them in a timely fashion? So that's one of the projects we're working on to decrease those observation numbers. But we always try to make them, you know, full admit status if possible. And the ones that are obs, it's not safe for them to be discharged, and we're working on ways to decrease that number.
But if they're not safe to be discharged, are we under code?
So I think it's the documentation that we would be looking at, and we are always working on making sure we're fully documenting because of the payers getting more and more restrict around whether it's an in or an outpatient. So we're constantly working with the providers on how do we document? Did we miss that? And so I don't know if you have more to say about that.
Well, there's a lot of work that's been done in the last couple of years that actually would be much worse had it not been done. One is when you hit the order to either order ops or inpatient admission, it asks you some questions. Ethics helps us with that too, to make the decisions. And then there are daily case management rounds. They look at every single patient. When do they qualify now for inpatient? They qualify. So it's continuous talk for that too. And regarding the faith base for the homeless, it's kind of fun. We have something called recuperative care, which is if they are homeless, all the way for out to a month stay with the Presbyterian Night Shelter and Salvation Army, where they can stay there if they're homeless to get IV transfusions or antibiotics for up to a month. So we do have some really good plans that help with all of that too. But there's a whole lot of work that's being done literally daily. It can always be better. But of the 5 hospitals that I've worked in, I've never seen a case management like here. Oxygen is at home the same day. I mean, I've never had that opportunity.
I don't think.
We can always be better. Yeah.
Right. No, I don't think, Dr. Fowler, I don't think I'm concerned about the clinical side of it.
Yeah.
I'm more concerned about throughput.
Well, and I think part of the driver is the volume, our ED volume. I mean, there's a lot more that are a little too sick to send home. But, I mean, just that overall volume is gonna drive up your total numbers. Maybe a little less
Yeah,
acuity, but they're still a little too sick to send home.
But for me, like ED, it's one part of the hospital.
Yeah.
We have 13,700 discharged. And that is 700 fewer cases. But each case should be around between $12,000 and $50,000 per cases. So that's an $8 to $10 million loss in volume base. So
And there's a
I'm more
lot of
looking at
work.
the throughput more than the clinical side. Clinical side, it is what it is. I think we have really good quality there. But the inefficiency or the throughput is what I'm worried about. That's what I'm trying to see. Is it documentation? It's the supporting behind the clinical, and you guys defending on the clinical side. I'm not a physician, so I won't touch that side of it.
No, you're right, we can do with the coding, are we capturing full complex? And that's kind of a very frequent educational thing. We captured one this morning.
Because what I'm trying to get is,
Yeah.
where's the signal so that operation people can sit down and say, okay, now here's where our opportunity is to support those lines of a business that we do, but if it's discharge, if it's, we can't discharge them, they have no place to go. Okay, now we look at potential $35 to $50 million loss opportunity a year. Okay, what can we do with it? Do we need to build more hospital, more apartment or wherever, or cut a deal with people to take care of them? Because that bed is not turning anything.
Yeah,
You're right, some cities have figured out the
Yeah.
cost, the homeless, pays for apartments.
yeah. So, yeah, so this is great conversation, because it is conversation that we have. I think we do have to look at who is coming in our front door right now. I think this is we have to reset. I also agree with you, DT, that, you know, we've got 4 years before this new hospital comes, and we've got to figure out not what are we going to do with the 520-some beds that we're licensed to admit to, but we have more volume that's coming through. Where are we going to put these? Because they're not all jail. They're not all needing, you know, long-term care. We've got to figure out kind of how we're going to take care of that additional capacity need before the 4 years. And so we, just this last week, had conversation. Is this kind of a hospital? And Parkland actually is building a new hospital in South Dallas, but I think those are conversations that we have to have as a safety net. Often you don't think of that when you're a safety net, that, you know, you're going to be outside of your the kind of big mothership. But I think we're going to have to think about that. How do we get those additional beds? Do we lease them from another hospital? Do we, you know, build a new one? But I agree with you. Dorothy, I think you also make a great point. How we are making the decision as who gets admitted, we have to revisit every aspect of that decision-making process to see whether it still is relevant and helps us with getting the next patient, you know, in a bed. And so, you know, I think right now the ED makes that decision. Is that the way it should be done? Should there be those who are taking care of the patient and discharging the patient that should be now involved in that decision? So all of that is conversation that we are having to really kind of look at things differently than how we've been doing it. But I think this is great conversation, and that we can't just make better what we're already doing, really have to now look at it with new and fresh lenses. So.
I know there are grants, folks, I had a meeting where they was getting grants to help folks that didn't have a safe place to go, and I'm thinking, well, who are you working with to kind of develop, is this just your family, or is this community? What hospital are you working with? So folks are talking about it. So now, you're right, we need to say, okay, you're creating some of those safe spaces. Let's make sure that some of JPS, you're working with JPS to identify some of their needs. So it's out there.
Yeah, the other thing is that, you know, if we don't have available bed, it's hard to attract commercial patient to come back. Right? And out of our $700 million base for commercial and of revenue, a 2% shift from commercial is already $14 million exposure. That's and so even the partial offset of it, that's $5 to $10 million margin impact. And so it's a concern if we short on staff or something like that. We need to staff so that we can discharge them, because there's no commercial patient wants delay. And if we continue without the throughput gaining on that, all we have back is going to be a much lower reimbursement type of patient. And we can't fulfill our mission, no money, no mission. It's very tough, okay?
Commercial are kind of funny. If they're real sick, they won't be here.
Right.
Maybe they're not that sick, sometimes they go elsewhere. But if they're real sick, they all.
Yeah. And I think they come and get that wonderful inpatient, and then that's the follow-up side that we really have to do. That's when we lose them, going to the specialists, it's way out and all that. So you're right, and I think that's that other piece that we have to look at to make sure that.
Yeah, I think we have to work on both sides. I think we have to work on the expense side and the revenue side. And to your point, Dorothy, if we can keep them from coming to the ED and being admitted, I think there's probably where there's more bang for our buck is to really control the costs. And so I know there's a lot of work that's being done with remote patient monitoring, hospital at home. There's work that's being done in the hospital as to how we can shift some of that care back out in the community. But
I think
Great point.
once we start talking about opportunity loss and stuff like that, it opened up a different conversation, I think.
It does.
Great conversation. We're gonna go right to payer mix, DT, so you took us right into payer mix.
Read the report.
Yeah, so this graphically just shows you the payer mix from last year, the budget, and then the current on the right side. And as you can see, Medicare is really relatively flat going from them. We are seeing a slight decline in commercial, that's primarily ACA space, not a decline in the number of patients, it's just a decline in the services, the mix of services. But we are seeing connection in Medicaid going up. Good thing self-pay is coming down because that's the most volatile between those three, because it's usually a very low pay there. And so we continue to see commercial Medicare, because Medicare would be our second best payer space. And so we're seeing an increase in our mission-based services that we provide to the community.
Could we get a little clarification? So commercial's our best payer, then second you said Medicare.
Medicare.
What would be third?
It would be Medicaid.
Okay, and then beyond that, could you explain connection, self-pay, and other?
Connection is our program for Tarrant County residents that we fund based on a tiered approach to those patients. And sometimes they pay nothing, and sometimes they pay a copay. Sometimes they have insurance, and we're supplementing their insurance because of where they fall in in their household revenue or income. And then other is everything else that we have. It may be jail, it may be motor vehicle accidents, those types of things.
So at some point, the connection, I guess I'd like to better understand how the underwriting, I mean, is it similar to what you would see Medicare underwriting patients, or, I've just got some newer folks on the board. I'm
Right.
just trying to better
Right. It's a
understand
good
how
question.
that looks.
Yeah, so similar, in a simple form, it is not an insurance plan.
Right.
It is where we meet with the patients, determine their eligibility for the program, and this is what's the ad valorem is meant to fund. This is the majority of what it funds, is so those patients need care. All their care is delivered at JPS, and if it cannot be, we negotiate with the local hospitals to provide that care, and that's what's called outside medical services that we pay for these residents if they have to go. So it is for lawfully present Tarrant County residents, and that the ad valorem is what's funding this program.
And do you specifically have to be a resident of Tarrant County?
Yes.
Okay, thank you.
As a provider, we learn pretty much what Medicare covers.
Right.
We know, I mean, really shouldn't have to drill down to what's covered, but we assume what Medicare covers is covered by Medicare.
Understood. Thank y'all.
Yeah, I might mention that, I invited the connection staff to my church, to make a presentation. One of the things I would say that they did do, those persons who didn't qualify basically for the connection program, they also walked them through, they helped them look at other programs, programs to, get healthcare coverage.
I see.
Right, and to Reverend's point, we have a team that looks to try funding sources for any patient who comes in, whether it's Medicaid or another funding source. And so we do all we can to find a funding source for their care.
Got you. Thank you.
All right, so as we looked at volume, which is basically the key driver for what we do, this is the short reconciliation that I do of the key drivers for performance. We'll focus just on the month to date. The volume impact we've talked about, it's about a $4 million impact because as Dorothy pointed out, the observation patients are paid less than we see on the inpatient side. Our rate is up, and our rate is primarily up. As you saw, the payer mix didn't look like it was moving, but we are getting some increased CHIRP, or Comprehensive Inpatient Reimbursement Program from the state that we had not planned on in the budget, and so we are seeing some increase coming through there. We're also seeing some revenue cycle improvement, particularly around the ED coding, level coding that we see. We're seeing the tune of $800 to $1 million a month coming through there. And then some also improvement in cash collections and denial reversals from the revenue cycle. The Medicaid supplemental payments, which those are the additional payments we get through the state, were favorable, will continue to be favorable. It's the HARP program, one of the supplemental payment programs, is higher than we anticipated in the budget. That program did not give us our final number until after we had closed out the budget last year. The next one, I'm going to talk about retail pharmacy. You may need to listen really carefully because we had what was called a reclass of revenue and expense last month. So it looks weird, but you'll see 1.7 on retail pharmacy, and then wages and benefits look really favorable. And I'm going to show you this on the income statement too. We had a change in how our employee benefit plan for pharmacy worked. We needed to change some of the computer programming that we had with the pharmacy benefit manager. That was changed as of April 1st. But we were overstating the expense for services delivered at the JPS pharmacy. For the year, it was $5.7 million. So the pharmacy was reflecting $5.7 million too much in revenue, and the expense was too high by 5.7. So we made that adjustment, we reduced the revenue, and we reduced the expense. You'll see it on the income statement in a minute, but those together net to zero to the bottom line. It's just moving it around on the income statement. So you see two odd variances when we look at year-to-date. It's right, it's just in the month we had to make an adjustment. You know, that's accounting, and we'll see that in a minute. So that's why the retail pharmacy program does look like it does for the month. The wages and benefits, again, we are seeing wages in line, benefits in line. We do continue to have a little bit of a pension expense that we had not anticipated. When we do our pensions expense every year, it is based on September 30th. We don't get that again until after the budget's done, and so interest rates can change. And so we do have a little bit of a negative variance throwing through there. Supplies and pharmaceuticals, pretty much on target. What you'll see, most of that is due to the patient assistance program. That expense, that is a revenue that directly offsets it. Provider services, you'll see that we had a little bit of the quality incentive was under budgeted. We had talked about that earlier in the year, so we'll continue to see a variance there for the year as we do each month. And then we also are seeing, excuse me, an increase in locums for surgery and internal med, I'm sorry, surgery and internal med right now. And so those will bring down as we recruit providers. The investment performance I pointed out, again, simply when you purchase a CD, and most of our investments are somewhere between 90 and 2 years. So I'm just going to use this as an example. We all know about the volatility in the market that's been going on, particularly around Iran and the Fed. When you buy a CD and you say for 90 days, I'm going to put $100,000 in for 3.5%, you will get your $100,000 back and the 3.5% as long as you hold it for 90 days, because that's the length of the CD. But during that 90 days, if all of a sudden interest rates go up to 4%, the value of that CD, if you were to cash it out, goes down. So everybody wants to buy the 4%. Nobody wants to save you if you want to get out of your CD early. All right, so that difference of what the market value is and what you are going to get if you keep it to maturity is called an unrealized gain. We have to record those on the income statement. They're unrealized. It just reflects the market value of your investment. It doesn't reflect something that we're going to lose in cash because of the type of investments that we have. So I just want to make sure everybody kind of followed me. It's called mark to market when you look at investments, but I think it's more like I'm going to sell something and it's going to be worth less, but if I hold it to when I'm supposed to hold it, I'm going to get what I thought I'd get. And so that's what this loss of unrealized gains is. It's a temporary accounting entry it will be cash we will get later, but we have to make estimates in the budget around what we think our gains are going to be, and they'll go up and down. Any questions on that? I didn't want to get too deep, but I wanted to make sure I didn't just say it was the market.
So just for clarification, so this month, we recognized a $6.5 million loss on the income statement, which is, in my mind, just a timing issue, as the rate volatility is what it is, and these investments or these assets find their way to maturity.
Correct. So if we hold all of our assets to maturity, that 6.5 will not be a loss
away.
on the investments.
Okay, thank you.
It's temporary, yep.
It's just, our money, whatever it was, at 3%, is still gonna be there. The market went up to 4, and now you have to show that difference. But that's just
Right.
paper.
It's just paper.
3% was still gonna be
Right,
there.
right.
Yeah.
Yeah, I mean, it kind of like, I mean, if you bought a stock for 10, and that stock is now worth, 5, or I'm sorry, or 15, your $10 stocks, worth a lot less, right? So, and it's just on paper.
Yep. Yep. So that's what's happening with that. So as we get our investments, it's a temporary accounting unrealized gain, it's called, because it's not been realized. You haven't cashed it in. So that's why it's unrealized. All right, so the income statement, I know this is a lot on here. I always box out total revenue, total expenses, operating income, and then the net income. The net income ties to what you've seen. I will take you to the third line, which says retail pharmacy. You'll see the negative variance of 6.3 million sitting there. That is that 5.7 I just described to you. And when you go down to the benefits line, you'll see a positive 4.9. That's where the other half of the other offsetting entry sits. As you look at the income statement, the net patient revenue is what goes through for the hospital and the physicians for billing. The supplemental Medicaid funding line, the net patient revenue also has Medicare DSH and comprehensive reimbursement program for Medicaid going through patient revenue. That's where they come through. It comes through on a volume basis, and that's how we receive it. The supplementals are calculated each year. They are based on cost and other formulas, and so that's why they're separated out onto a separate line. They're not volume related based on what we're seeing. They are sort of volume related, but they're retrospective calculations, and then they're fixed for the year and settled on during the year. The retail pharmacy line, again, is our retail pharmacy, the central fill, the specialty pharmacy that we have. And the other, the biggest thing in the other, that's where the tobacco revenue would come through. That's where the pharmacy assistance program runs through, and so some other things. Anything where we would be leasing to someone, that would come through there. And on the operating expenses, you see wages. Wages are favorable. You'll see in a moment that our FTEs per adjusted patient day, down lower than last year. Our FTEs are down. Our contract labor up a little bit. As I mentioned earlier, we have some locums in for surgery and internal med. That is driving that up again, looking at a plan to reduce that. And then the benefits we had chatted about. The rest of the expenses that you see, the non-labor expenses, so the supplies and pharmaceuticals, again, unfavorable, but we had some implants over budget for the month. We had then the pharmacy assistance program in there. Purchase services also includes professional fees, just if you're wondering what sits in purchase services, that would be like our radiologists, our hospitalists, all the physician-based services that support the inpatient hospital. The variance you're seeing for this line is primarily due to the recognition of the soil removal for the new hospital. And so again, it wasn't in the capital, it was in the budget, but it's not part of the capital budget, it's part of the operating budget. And so we are slowly expensing that through this fiscal year, and we'll have it fully expensed this year. Depreciation is just a result of timing of our capital expenditures, which I'll talk about in a moment. And then other operating expenses, those are leases, maintenance and repairs, utilities, our insurance, all those type of other expenses that we have to run the organization, just to give you some flavor for what's in each of these line items. So Dustin, we have some new people, and just to give you a little flavor for these.
No, and I appreciate that, and just real quickly, you'd mentioned the environmental that's packaged in the purchase services, is that correct?
Correct. It's a purchase service to remove this contaminated soil.
So it's not, it's going to run through the income statement. So it's not a balance sheet item. What is the total, and what does that look like for the remediation for the new hospital?
When you say remediation.
Well, I'm sorry, the environmental.
Okay, so, the $2.5 billion is the capital investment that we need to
Right.
make. And as we look at the whole project, this is an operating expense. And so it's about $9 million. And it needs to be expensed as part of operations as we move forward. If we find other things that, then it's determined based on, I hate to use this, but accounting standards on whether it's capital or
Right.
whether it's expense. And so soil removal, asbestos removal, contaminated soil, those types of things all become an operating expense.
So we're currently at $9 million, and that's estimated, is that correct?
We're accruing to $9 million by the end of the year.
I see, okay.
And we expect to spend it by the end of the year.
Versus capitalizing it?
Yes.
Okay, thank you.
Groundwater impacts, groundwater contamination, that would be another expense.
Yep, we never know when we start digging
Right,
what we'll find.
thank you.
You're welcome. The next page are the operating ratios, maybe, whoops, sorry. We've gone through a lot of these. I think what I'd like to do just briefly, though, is you have the margins on the top. The labor expense ratio, again, is our labor as a ratio to our net patient revenue. And that's what, it's looking at the monies that we collect that are related to the volumes we serve. As we look at total, overtime and contract labor as a percent of salaries, we are favorable to, budget on overtime contract labor a little bit over, but we are favorable to last year, so we are continuing to monitor and look at that. And then the FTEs have come down both, on an annual basis as well as year-to-date, and you'll see our FTEs per adjusted patient day, is 5.3 for the month, 5.6 for the year, and it continues to come down from 5.8 for last year. So again, steadily working on the workforce optimization, that has rolled out. We are finishing that up with a couple key areas that are left to roll out. Really seeing some great progress by leadership on looking at how we right-size the staffing to take care of the population we're serving. And then the balance sheet, we have just above $900 million in unrestricted cash. That's our operating cash if you're tying it to the balance sheet. And I'm gonna actually go to the next page to talk about the other, we're gonna go 2 pages to talk about the other 2 ratios. I'm gonna skip the balance sheet just for a minute. So days cash on hand, we are at 476 right now. For days cash on hand, about 194 for operating cash. The difference between those two is the future fund versus our operating cash to run the business, spend for regular capital, pay our debt. So we are in a good place right now. I did move another $50 million in March to the future fund, and actually I moved another $50 million last week to the future fund. We have moved this year, based on this year's operations, $92 million so far through March to the future fund. You may remember, for those of you who were in December, we moved $107 million in December, but 65 million of that related to cash generated from the prior year. So just trying to separate the two. Generated from operations this year has been 92 million and another 50 last week. So we've 142 million as of today has been moved into the future fund. I'm really trying to get down close to 180 days because we have different investment strategies around the future fund with more absolute knowledge of when the spending occurs. So we're continuing to watch that as we move forward. I'm gonna show you the cash flows for the future fund in just a minute, but I don't know if there's other questions on cash before I talk about AR.
Kim, I've got a few questions. What is our requirement per our operating agreement? How many days cash on hand are we required to have?
The board has set a floor of 180 days, and if we go under that for more than 6 months, management's required to produce an action plan.
So we exceed that currently?
Correct.
Based on
We
what I
did-
see here?
Yeah, we did go below a couple months, December November.
So the green line, that is the Moody's requirement, right? And I guess, could you explain that to us, exactly what that means?
Sure, so all the rating, well, 3 of the rating agencies publish benchmarks that are based on their ratings. And Moody's, AA, similar to S&P and Fitch, KBRA or Kroll does not publish the benchmarks of the 4. But they all publish what they think on average a AA-rated organization should be achieving. And it's a combination of things. It's days of cash, it's operating performance, it's the volatility of your revenue streams, and then they also weigh in the environment. And so, so this for cash, even though we're below that line, our revenue streams, they feel are more secure, they feel that our environment is not as volatile as others, and we've actually showed good income statement performance since 2020.
And the major driver behind that is the bonds.
Yes, it's our debt rating that allows us to get the interest rates
We've got to be
lower.
pretty mindful of where we stand moving forward.
Yes,
Thank you.
good questions.
Okay, could you go back, the screen before that, the performance ratio? This one. So the, current net margin, is 9.2, right?
Year to date. Year to date.
And the prior year was 16.7.
Right, the prior year, the DT had about $50 million of one-times in it.
So if you take that out,
We're pretty comparable to the prior year.
because what I see,
Well, I think a combination of the one-times plus this, I mean, I hate to keep harping on the $6 million, but do you know the timing? I mean, it's going to have a whipsaw where we see it back on the income statement.
Depends on the market,
Yeah. So who knows?
who knows?
Okay.
so we're not concerned about that 45% drop in margin. Net margin.
I'm not concerned about that because those one-times are not predictable. I'm always concerned about performance overall, though, DT, in order to move forward and fund our future.
Because I'm a little bit concerned about the low investment income and the,
Well, the investment income, again, is a market-driven, a mark-to-market, so it's all unrealized gains. And so depending on where the market's moving, we will still get the return out of those investments as long as we hold them to maturity.
And I guess maybe that was more so my question is, I mean, any idea what that maturity looks like?
I can look at the ladder, it factors in during the year. We have investments that expire as soon as 90 days and some as 2
Right.
years. So as we look at them,
Yeah, I mean,
Yeah.
is the majority of that exposure pretty short-term?
it's very short-term,
Okay.
a lot of it's short-term. I've been,
So
as
hopefully in
I'm,
the next 6 to 12 months, we see this
oh, yeah.
correct
If,
itself.
if you're looking at that short, sorry, I'm thinking in my equity brain,
Right.
equity side of my brain. Yeah, we should see it in the next 6 to 12 months.
Okay,
And that's actually how we're doing investments and filling in our investment spaces, is looking at, do we really want a 90-day or we want a 180-day? Or we want this based on where the market's been moving? And we work with Hilltop on that very closely.
so I see our budget was 6.9%, we're 9.2, could be a little higher if we didn't have this timing issue, right? That next line item, I see the budget was 1.6, we're at actual 4.8. Is that 1.6 after the court set our tax rate?
Yes,
Okay, so we're still far exceeding the budget,
right now we are.
correct?
it's
Okay.
exceeding, but we have to be very careful.
Right,
Because what I see is the decline, right? If we drop another 3 to 5%, that's another 20 to 40 million dollars in earning impact for us.
right,
So as we go into the budget,
right.
we need to keep that in line, because that swing could kill us if we can't explain it. A tax rate can be very damaging.
Right.
That's what I'm trying to get to, is that when I look at those numbers, I'm worried about how we craft the story, present it to the board.
We're not recovering as quickly from these tax cuts as we were
Rising costs,
previously,
3 to
is what you're
5%. Right.
saying, even though it's still showing, some above what we need. it is showing that every year we're having more of a difficult time, especially in a year like this where we don't get these kind of gifts given
Right.
to us.
Right.
That it makes it harder and harder for us to squeeze more out.
Makes sense.
The profitable is, for now, we okay, but we have to look further out as well. We all concerned, but we didn't tell the story correctly as well.
Because I think
Get to
we've
those
done,
impacts.
I think we've done a good job and kind of the low-hanging fruit. Now it's becoming much more difficult, hence the kind of conversation we had earlier, because those are going to be your harder decisions that we have to make.
All right, I do want to bump back forward to net days in AR. As I've mentioned in the last few meetings, we expect the AR to increase as we improve revenue cycle because we are slowing down the write-off process, which means we're working denials more heavily. We did see, though, an impact, we did see an increase this month of about 4 days. 3 of that days was actually due to that pharmacy revenue shift that I explained earlier. And so we're really at 50 days, but we're gonna be high because that pharmacy revenue is about 3 days of that adjustment we made. But we do have some other things going on. We have one patient that is over almost $4 million that is sitting out there that we are working. It is a commercial patient, and commercial patients pay outliers, and so we're working on that patient, but it's still sitting in the AR, so that's a day and a half in and of itself. And then we have with the longer length of stay, we see an increase of unbilled because we have the longer length of stays now, and so we're seeing a higher unbilled. We aren't seeing any delays in payer activity right now, like all of a sudden, Blue Cross Blue Shield is taking 120 days to pay instead of 90 days to pay on average, so we watch that. But we'll continue to watch all these flags as this goes up. I expect this to start, this is gonna level off a little bit, it'll come down a little bit, but we are still working on some process improvement around the AR. We are seeing a lift, though. Revenue cycle has made some nice improvements. We're seeing the cash come in healthier. I just did a hindsight review, which means I looked at 12 months ago what we thought we would collect compared to what we collected over the last 12 months, and we're pretty much right on target. And so knowing that we are collecting pretty healthily against what we expect on our cash projections.
What is our DNFB now?
Our DNFB is pretty low, DT. It's a couple days.
Couple days.
Well, if I take out the longer length of stays, when you say, are you talking about DNFB or DNFC?
DFB
DNFB, that's gonna be about 10 days.
days.
Yeah.
What's our policy?
Pardon?
What's our policy?
Our policy, our DNFB does depend on documentation, right, and getting some documentation, but we don't have an official policy, but I never want to see any discharge not final bill going over 30 days. Individual accounts, because sometimes we're collecting.
I come from a different world, right? DNFB should not be shorter than 4 days, because you want to get all the charges from every department in, so you don't have to correct it.
Oh, yeah, and I didn't include the bill hold when I gave you that number, so you need to add 4 more days onto that, sorry.
Okay.
Discharge not final bill would be 14 if you want to add the hold days. So we have 3-day hold for outpatient and 4-day hold for inpatient.
DNFB.
Discharge not final billed, sorry. So that means it's sitting, the patient's been discharged, but we haven't done a final bill. We hold outpatients for 3 days because they're simpler. And then we have inpatients we hold for 4 days, because usually if you go over a weekend, you need Monday and Friday, right? Or the 2 days for getting all the charges in, the documentation in, and sometimes we're not ready to bill because we haven't finished the documentation, or we don't have an HMP, or we don't have something that's necessary to send a clean bill out the door. So there's work that the health information management and coding department does in order to make sure we get a clean claim out, meaning it goes to the payer, and hopefully we get just paid and we don't get denials or questions and things like that. Good question.
So I hear the explanations here on why it's up. Is there concern in your opinion?
AR keeps me up at night.
Okay.
No matter where I work, just so you know,
Right.
because it's not unique to JPS.
But some of
So-
this is a one-time, like you said, the retail pharmacy is baked into this. And we've
That-
got one extraordinary case, it's a large ticket item, right?
And we do have extraordinary cases quite frequently, but this one just happened to pop up into to the.
And you said that one equated to a day and a half?
Mm-hmm.
Okay,
A day of AR is $2.8 million, just to give you an
Right.
idea. So 11 days would be $30 million.
so if you net some of that out, does it get back to that 50 days or less, in your opinion? Okay.
Oh, absolutely.
Okay.
Absolutely, and I think that's always the target. Our net, and it says net days, and Demetria, this is another thing. Net days means what we expect to collect accounts receivable. It's not our charges. This is what we expect to collect. This is so, if you have a business and you expect to collect $100 from a vendor, this is the same thing. This is
Right.
what we expect to collect for services. We do have a large self-pay bucket that does age a lot because we have a process that we have to drop 4 bills, so that's 120 days. If the patient doesn't respond, then it goes to collections. And that's Medicare guidance is 4 bills before 120 days before you can, so we follow the same process for all patients.
So Kim, does this take into account what you write off?
What we write off is not included in here, it would be gone. So before,
Writing off less of that,
it would be in here.
okay.
So if we write off sooner, it brings the AR down faster. And if you hold it, it makes it larger until you get to a stable state and you say, I think I'm always gonna have 48 days because of this. Does that make sense for the group?
Help me understand, I think my math is wrong, so you said 2.8 per day
Right.
AR. I only see 1.9 per day, so are you including the JPS connection in this?
Pharmacy is included in that number. The retail pharmacy is included in there.
So when I look at AR days, I look at the 693 million. And what number are you looking at?
So you're looking at 693 from the balance sheet. I would have to go back through the balance sheet because there's some things in there that we'd need to look at.
Because I take the 693 divided by 365, I can only get 1.9, and yours is 2.8, so that's where I'm trying to reconcile the difference between.
Sure,
on
sure.
this.
I was thinking, if a patient's a resident and they don't have insurance, we try to have them on JPS Connect before we deem them self-pay. How long do we exercise that process before we say you're self-pay?
So for JPS connection, it depends on if they, we just try to get them qualified and get the paperwork, and as soon as they qualify, they would go to connection. We also have patients that are self-pay that are pending Medicaid. So we're waiting and waiting and waiting for Medicaid. So that's another one that will increase the AR too, depending. And we had there's another couple days in here around conversion. So we had a couple patients that converted really late. They became pending, then they were self-pay, and then, now they're Medicaid. So they sit there.
And it's worth waiting, because you end up getting payment in the end. but
Correct.
They are long.
Correct. Correct. Good question. All right, I know we're flying through. This is cash. This is the cash flow. Basically looking at, if you look at the bottom right, where we started at the beginning of the year at 877 million. If you look at the balance sheet, it's 914 is the operating cash. I'm just gonna point out, there's the collections on AR, there's the ad valorem that we've received this year. We have the majority of it now. The two lines, the capital expenditures, you'll see $73 million. 73 million is 55 million for the master facility plan, another 18 million for routine. We expect to see another 30 million for routine coming through this year for expenditures. We tend to spend more of it in the second half of the year. And then you see the piece of the debt payments that we had so far in the first 6 months of the year. So we have 3 debt issuances. One will expire next year, one in 29, and then we have the 2023 issue that we have that is the 450 million, so 3 debt issuances that we have. So what we will be doing is to give you a different view on this, is we're gonna start showing you how we're performing, and then if whatever our bottom line is, what we're using that bottom line for. So you'll know that this much is going to capital, this much is going to cover debt, and this much is gonna cover capital debt. I had one more thing. So capital, debt, I don't know, my brain just went away for a minute. So it's capital and debt and what we're spending it on, the things that hit the balance sheet. Because the income statement doesn't account for the capital expenditures, it accounts for the depreciation on the capital expenditures. So I think it's important as we look at the net income for the organization, that you understand where that net income is being spent. Does that make sense to everybody? We also have the debt on the balance sheet, which is about $220 million today. And that's actually what we've been using on the master facility plan right now. So the future fund, or the board designated for the future fund, has not been spent down yet. So, but the debt is not included in the cash right now. So there's a lot of complexities as we go through this. What you'll see next is the master facility plan, these two slides. So you'll see the budget, which is 2446. There is a line that we did remove. We removed the last line, which was the demo of the old hospital, which was about $38 million. It's still there. It's just that we're looking over the next few years, what are the options around that facility, or this facility, sorry, that we're sitting in. And so we really truly wanted to look at just the projects right now. And then we're gonna be looking at what the options are for the old facility at a later time. The activity in the green are the payments, that's cash out the door. What we've committed as contracts that has not been paid yet. So we have a total of $948 million that has been committed, almost $1 billion for the project. So we have $1.5 billion left remaining in this project. How is it spent? This again is, on the left is cash flow by quarter. On the right is the cumulative cash flow. And as a reminder, the dotted line is the projection from the last quarter, what we thought last quarter we would spend. The bars are what the new projection is, but if the bar is green, that's a true cash out the door number. The yellow are the projected bars. So basically you're looking at green bars are what we've spent, yellow bars are the new projection. So you can kind of see as we're looking, we're gonna peak out as we get to fiscal 28, the second quarter of fiscal 28. So again, continue right now, we're gonna see an acceleration of this spend. So we'll continue to, we monitor this monthly, but we share it with you guys on a quarterly basis. If there's anything that needs to be flagged, I will bring it up at the monthly meeting, but we continue to work with Ramon and Brian on these quarterly forecasts of our cash flow, which also informs our investments that we're making with these funds.
Yeah, question for you, Kim. Could we go back to that prior slide?
Maybe? There you go.
So I know, I see that we're at 2.446 billion, and this has increased many times since the inception of this bond. In your opinion, I mean, the big ticket item is this hospital that we just kicked off at $1.5 billion, right? How solid, how firm do we feel that this budget is today, kind of moving forward, in your opinion?
I think.
I know it's a moving target.
Yeah,
but
it's a moving target. I think with any large facility plan, there are risks in your budget. We don't know, for example, we talked earlier about when we start digging the hole, what we'll find.
Right.
Right? We don't know if there's gonna be a full embargo and steel all of a sudden goes through the roof, although we're trying to plan for that and purchase in advance. So I think where we're sitting today is what we feel is the right budget, but there are a lot of unknowns.
So that budget, I mean, a lot of this has been built, and I mean, I feel like we're a long ways down the pike here. Is the budget, I mean, is that comprised of all parties involved, from, you know, our GC to staff here internal, to the third-party folks that we have that are overseeing the program managing? Is that?
So this is the capital budget. This is basically the capital investment, and it includes many of the things, but if we have staff who are working on it, that's sitting in operations. Is Brian behind me?
Yes.
Oh, you wanna come up here?
Yeah, that's correct. Other than internal staff, this is total project costs. Design fees, construction,
Right.
furniture, medical equipment, it's all wrapped up.
Okay.
So I think I'm looking at it a little bit differently than you are. I think time is working against us. And I think the uncertainty that's going on across the world,
Right.
that's going on closer to home, that this keeps me up a little bit.
Right.
as to whether we can say this is going to be our final, you know, cost of the, so we may have to shell more space, we may not be able to, you know, I think we've done a lot of trimming as much as we can.
Right.
But it does concern me that what we have planned for the hospital to look like and to have could change unless we're able to be more adaptable to any increase in
Sure.
costs that come through.
That's right. And I would agree. I mean, just this last year, what did the budget increase from? Wasn't it nearly two or something? And we've increased it to 2.5, and now here we go again. I mean, we've got all these global affairs and fuel prices are up. So that's just was my concern is where do we really think we stand and what kind of contingency do we have in this budget? You know, as we're seeing impacts to the P&L income statement here, seeing that contract and see some expansion on this. I mean, you know, not to mention we get it built, just the transition, getting it from here to there. And, you know, anyways, it's just a concern, and I'm just curious to see, you know, or to hear more as obviously keep our, you know, our thumb on the pulse here as this deal progresses, because it's still the biggest ticket item out of the master plan, so.
And you make a good point on, I mean, this is just the
That's right.
capital, it's not even the operational.
I mean, it's
cost.
kind of, I mean, you buy you buy a house, that's, you know, that's the tip of the iceberg. Then you got to go
That's
furnish
true.
it and move into it and,
So Kim will bring that forward as we're
Right.
looking at what that is and how we're responding to those increases in
do,
operational.
do we know what percentage of contingencies in that $1.5 billion? Is it 5% or is it 10% or?
It's
Maybe this is a
4,
Brian
Brian,
question.
4?
Yeah, so, in the IGMP, the contractor holds, 3% on the hospital, 3.5%, and then JPS holds, around 4%.
Okay, so we got 7%-ish
Yes.
currently in that budget?
Correct.
Okay. Gotcha.
Now, familiar with those contracts, that's the entire part. The one thing that I would maybe throw into the equation is, you know, our approach on the job being guaranteed maximum price. So by the end of this year, the MOP and the CUP will be 100% locked in. The hospital is locked in at a maximum price.
I see.
April of next year. So even though we're not occupying for several years, we put in the ability to lock our maximum price.
So we have exposure on the hospital between now and next April is what I'm hearing? Okay. Got you. Okay. Thank you.
Okay. All right. So the last thing is the financial goals. We've talked about most of these already that are in the red. We are meeting, these are the annual targets that are in the column. You will see the one at the very bottom, connection, our patients served has increased past budget in the 6th month of the year, so we are serving within where we expected. Length of stay we talked about already, and we talked about AR days. And so I think as we move forward, we continue to monitor these. There are other things that we do monitor, but we want to watch most of these are lagging indicators. A few of them are leading indicators as we're going. So any other questions from the committee about the financial report?
I have one. Back on the master facilities plan, I know we've talked about our new system, we've adopted the Tchd system. Who's gonna be, and I know Jill's not here, maybe Brian can answer this, but I think we're gonna need, or I suggest that we have an internal JPS administrator that's gonna be operating that Lawson system, where the pay system, pay application report, wherever that pay application report is gonna come out of. And can that person come to one of our meetings? Because it's gonna be important when we're tracking, because Brian said something that was very important. He says, this is our capital budget, and everything is included in here. So in that system, it's tracking your construction. It's gonna have to be tailored to that. You know, it's gonna have to be tailored to what's construction cost, what's gonna be your equipment cost. I think we need to really talk about that to be able to capture where those dollars are gonna be spent.
And the system does do that. in
But
those
BTG
major
has
lines.
to be told to do that, so that's why the administrator, there has to be an administrator that's gonna be administering that system, because it's like any data system, you know, garbage in, garbage out, right? So it's gonna have to be determined what we're spending, because typically, you just have your construction costs, and then your other stuff is kept a different way. It's through another system. Does that make sense?
It
Or you
does.
just have everything on in one lump, how are you gonna know what's construction, what do you know if it's gonna be for the x-ray room or the ER room? Because that's, it equally has a high expense to it,
So
right?
Dimitri, I'll take that away with Brian, because in our tracking system, we do track it all broken out by a lot of that already. And so let me align with
Yeah, I'm
Brian.
just talking about the B2G system, because I'm not
Right.
familiar with the other systems that
Right.
use it. I'm
That's,
talking-
that's why, let me align with Brian on that.
But we'll work within our
Okay.
current,
I'm just standing, because I think it's kind of getting pushed to the side every time I bring it up. because
no,
there's
actually, this comes up every Monday, because
Okay.
you have
Yeah.
been on us like I'm like, I'm just like you, where are we at with this? Because
Yeah.
Dimitri is gonna bring it up again,
Well,
but,
because it is, 'cause
yeah.
we're already buying,
Yeah.
we're buying long lead items right now. You know, you mentioned the steel, I mean, we're buying bundles of
That's
stuff right now. Where are those charges being put right now?
Yeah.
I mean, I know they're all lumped up into the, what do you call it, operating expense?
No, they're sitting in the various categories that need to be, if we've spent the money, or if it's been contracted, it's sitting in that line.
so we will get a guru, someone that you know is working on that system.
But right now, that line item is not showing up on the financial. If it is.
Should be in the balance sheet, right?
It's
I
on
mean,
the
you're
balance
capitalizing
sheet.
it.
It's something else, it's not
Right.
split out to see, because that
It-
goes back to Colin's thing, how are you gonna be able to audit something if you don't know what you're looking for? How are you gonna be able to audit those construction dollars if it's all lumped up into, anyway, that's just my thinking. I mean,
It's, and we'll work through it, Dimitri. It's not all lumped up, so we will work through that. And we'll be bringing more clarity as we get into the project, but it's not on the income statement. It is, to Dustin's point, on the balance sheet, and that's where, if it's spent. Otherwise, it's sitting in the system, and as I had shown, this report comes out of that system that shows by area, the payments and the committed. So when you see the new hospital line and we have 175 million total committed and paid, that's broken out by major lines. So construction.
We don't see that.
No, you don't, but we can,
I would like to see it, would you like to see it?
Yeah, and to, I mean, to your point, I mean, this would be, it's administered by us, right? This is not Ramon or Austin, right? This is an internal
That's what
feature,
I'm asking, you know, you need an administrator.
right?
Right, into the system to get it set up.
Mhm.
Then Ramon will have his person to be putting those payments into the system.
Right.
To make sure, you know, the GC, you know, Jay Dunn got paid, Austin got paid, and then it goes from there. But there's another layer before it even get
Mhm.
to that. And I think, and I don't know, but I think that that's where a big gap was with the previous round that you guys were doing. Now I wasn't involved in it.
Yeah, I don't recall a gap, but with that said,
Well,
I
I'm just
think
saying,
you,
the gap-
Dimitri, when you see a project and you have a hospital, you're gonna have construction, fixtures and equipment, movable, you're gonna have a bunch of major lines that associated, and those are, we can look at how that can be reported out.
I'm running about 4 projects in the system, so I definitely understand how the system runs. I just wanna know how we were gonna run it, and who's gonna be responsible for that. I mean, that's all I'm asking, who's gonna be responsible, because if it's not planned out, it's gonna be a mess.
yeah, so valid, we will take that back and we will answer that. And then Colin, when's the last construction audit that we've had?
We have one that is being contracted right now.
Okay. Because I think that's also important for the board to see.
Okay,
So we need approval.
all right, if I could get a motion for the unaudited March financials, please. Got a first, we got a second, all in favor? Any opposed? The motion carries. Okay, thank you for that, Kim.
All right.
All right, I have got you running the rest of these items, is that right?
Just the IT ones.
Okay.
Then we'll rotate in who needs to do the other ones.
Okay, all right, so we've got, item B here is to consider approval of a professional service agreement between Tarrant County Hospital and Experis US LLC.
Yes, this contract was put out for RFP. It is a new service contract for the organization. We had 9 respondents to the RFP. We are looking for a cost of up to $2,013,798 for a 3-year term. This is actually to help cover the IT help desk that we have that is staffed 24/7. 80% of our calls, though, come in between 6 in the morning and 6 at night. And so having people staffing at night and on weekends, which are hard to recruit positions, we would be using this service to help augment that, as well as augment during emergent times where we need more people on the help desk answering calls. So this is what it would be used. It's on a per click or per use basis, so it's volume related, so that's why it's a not to exceed.
I have a couple of questions on this contract. I know that it says it's gonna help the desk up, and it's kind of set like it's gonna, for non-essential hours. So what is your, wait time? How long does it take to get a phone answered now?
It's pretty quick. It's pretty quick. We usually have a few people on at a time.
So I'm concerned that we are doing a 3-year contract for IT. When you look at what's in the contract, it is to me like a management where you could end up outsourcing the whole department. Because it's talking about 30,000 calls per month. Based on what come in, you get a discount. So this to me does not look like it's a backup for staff. This is not a staffing contract. And I'm concerned with how this is set up. Because it's, to me, we have all the makings of being able to have this whole department outsourced, because it is totally in this packet. When you go down and read the contract, that is the calls and all of the setup and talking about, you know, the criteria that they've set up. So I'm concerned that this is not a staffing for overflow. It's more to me like this could easily be an outsource and you would never know it. It's set up to be that way.
So Dorothy, I appreciate that. I believe the contract was set up in a way that these are very tough to recruit roles because they're basic roles in the organization, that they're basically directing traffic. So it's really meant to be on a per-click basis, so that's why there's such a high cost that's being asked from the board. So really to cover the nights and the weekends, and then if we have people who call in sick and we can't cover them.
Well, I also know that for nursing department, every other department has staffing needs, and they do not set up a contract in this manner to cover that. That is a staffing where you can have an agent that you can call. So I will say it again, if you read all the details in this contract, it is more outsourcing how you can, all this could be outsourced. That is my concern on how this is set up. And that is one of the reasons that I will be rejecting this contract.
What would be the cost for us to actually staff those hours that we currently don't staff? Have we looked at?
Yes, it would be 12 hours a day, one person, so that's 2.1 FTEs, 2.5 FTEs, so that would be on the average about $400,000 to $500,000 a year for these help desk people. They're pretty pricey.
And I gather we haven't tried to staff our own area. But I asked what are the hours. It says it's 24/7 now. And so we are not operating 24/7 now?
Yes, we are.
So, okay, so it is a staffing need, and if you need staff, I would suggest we try to recruit staff. And you can set up a contract for, that says when you need staff, it will come in. It doesn't have all this other stuff that says, you provide your computers, and this is the whole, if you look at it, everything can be done with this contract with an outside people. And so to me, I did not read it as a staffing contract. We contract people all the time, and so this is not set up that way.
This is, for a help desk for IT, it's a remote staffing arrangement to help cover the excess. It's not my intent to outsource the full help desk. We are having a tough time staffing nights and weekends because of the role it plays.
Is this more for email problem, password type thing, or is it more Epic and other systems?
It's everything. If you have a problem, you can't log in, this is the first path of escalation. Something's wrong with Epic, you call the help desk, and then they escalate if it's a priority one. We get about 80 calls between 6 at night and 6 in the morning for that 12-hour period of time.
Just on a per click basis? So is there a base cost and then the per click beyond that? So there's no cost and no one call?
Correct.
What is the SLA on this one? I didn't get a chance to read it. Because if they take the calls that we got it, and then they don't solve anything, we still pay for it?
Right, we actually will tell them when we want them to do the service. They're not just 24/7 available to answer the phones. So this is one where we would say between 6 at night and 6 in the morning on Tuesday, we need you to answer the phone. We're having emergency, we would call them up and say we need to do an augmentation because we're having an emergency issue and everybody's calling in and our people that are answering the phones, the 3 people on the help desk cannot take care and answer the phones timely.
So the thought would be you could, so just to reiterate, there's no cost if no one uses it.
Correct.
So you could look at staffing needs, and I mean, if you have a couple of people that are scheduled and somebody's sick and they don't make it in, then they can roll over.
Are they onshore or offshore?
Good question. I do not know the answer to that.
If it's offshore, we can't understand, can't do it. And
Yeah, let me,
CMS is moving that way. You cannot offshore.
no, I'm pretty sure it's onshore DT, but I don't want to give you the wrong answer. I'll find out.
No. Well, if it
And
was
is it-
written up that way, I would have saw it.
And be careful, they may have
Yeah, I'm
AI
pretty sure it's
into it.
onshore, but I would hate to give you an answer. I usually ask that question on every contract like this, so.
Can somebody find out to see if they actually answer or they have AI on the
It's
other side?
called Experis US.
Yeah.
Yes, that's the United States.
I like that you're
When I see that,
anticipating-
it
Yeah.
scares me
Oh, it did?
Yeah.
Okay.
because they have a sales office here.
Yeah.
I like that you're anticipating the need, because I will tell
You
you,
know,
as a
I'm not opposed to having a staffing contract. I'm just opposed to having it where it can be outsourced without you knowing. Because it is there, that the way the proposal, the reason I brought this so I can pull it up and show it. If we need staff and with this is not the only department that has hard time getting stuff, and so you can do a staffing contract, but it is not a staffing contract that you're paid by, most of them, you're paying them an hourly rate. This one is talking about doing calls.
Let's table it. Dr. Kirby, did you have something?
Thank you. I was going to support the concept, so I love that you're being proactive. I will tell you from a patient safety perspective and a physician engagement perspective, there's nothing more frustrating than trying to take care of a patient. You go to your computer, you're locked out, you have a trauma patient you're trying to put orders in on, and every time I pick up the phone to call IT, they answer right away, they're responsive, they fix the problem. So if we feel like we need a more robust system to keep staffing that, it's been very successful, and I love knowing that if I have to pick up the phone, there's someone immediately available. So if you foresee we have a problem and that we're gonna need more coverage, we have to figure out a way how to do that, because taking care of patients demands that this is in place. And we love that service. That keeps, if you don't have that, the docs are gonna be angry, the patients won't be cared for, and we appreciate that availability.
Kim, is there any urgency on this contract?
We're having staffing problems and we have burnout on the help desk because we have people who are working excessive.
Is there urgency on this? Can we bring it back next month?
We can bring it back next month.
Why don't we?
Yeah, I think so. I think the recommendation is to table
I
it,
think there
and
were
let's
some good
look at the
concerns.
economics of hiring it in-house, and, is it onshore, offshore, or,
I agree.
is it a backstop as needed, so,
It's actually onshore.
Okay.
So, which is it just got, so they're
okay.
very quick.
Thank you.
If I could get a motion?
I don't
Motion to
think,
table.
I'm sorry, you have a motion to table, is that right?
Table it.
Okay, I did, okay.
Okay.
All in favor? Okay, any opposed? Okay. Item B is tabled, okay. Item C is to consider approval of 1 exemption to bid and 2 contract between Tarrant County Hospital District and Tchd, Inc.
Yes, Up to Date is the internet-based clinical decision support tool that is integrated into Epic, and it is used 24/7 to guide patient care decisions across in and outpatient. It's used about 40,000 times a month by 500-plus users, and it is their core access to key information. And so we are asking for a 5-year agreement at $2,345,787. This does have a without cause after the 3rd year of the agreement, and for years 3 and 4. However, we're asking for the full cost of the agreement.
Is this the company that we're currently using?
yes.
Yes. And it's an exemption because it's integrated into Epic already as part of our tool.
After 3 years, we're not bound to continue.
It's been around forever. I'm just saying.
We've been bound.
The little green books I used to carry.
Yeah, we believe there'll be an AI solution that we can replace this with, so.
I think open evidence is gonna take the place of.
I do too.
But I think 3 years is a reasonable period of time.
Okay.
Great.
I questioned that.
There's no further questions. If I could get a motion.
Move approval.
Get a first? Got a second? All in favor? Any opposed? Okay, that motion carries. All right, we are on to item D, to consider approval of addendum to DIR contract, DIR CPO 5347, Cisco network switch between Tarrant County Hospital District and General Health Data Tech LP 1369311.
Yeah. So Chuck, for your purposes, DIR is Department of Information Resources of the state of Texas. I don't know if you're familiar with this, but they are like a GPO and they already pre-bid. They pre-bid them all, so we don't have to go through an RFP process. So I didn't know if you were aware of that. This is looking for approval for $849,794.94. It is actually to replace the 42 switches that are beyond life right now in the organization, and we're having tough times. They tend to fail from time to time, and so it's getting them finished by the end of this summer. It says 3 years because that's the term of the agreement, but we plan to get this work all done by the end of the fiscal year.
We've been working on these.
We
switches
have piecemealed this and brought it back to you in little pieces. And so we have made the decision that we're going to move forward with getting this done in one big swoop, so.
Every switch requires some downtime, and so that's why it's a challenge to us. But we made the commitment, we want to get all 42 done by the end of the summer.
Okay, if I could get a motion.
Move approval.
First and second, all in favor? Any opposed? Okay, item E is to consider approval of 1 exemption bid and 2 order form between Tarrant County Hospital District and Health Recovery Solutions.
Yes, so this is a contract. The exemption to bid is around we're using this vendor today. It is a remote patient monitoring vendor, and we use it for about 225 patients right now are being remotely monitored, and we need to increase the contract price to accommodate growth in this program, which we really see as an opportunity to reduce length of stay in the hospital as one of the primary, as well as give people a better quality of life. And so we're asking for a 1-year extension, adding $213,120 to this agreement.
No questions? Okay, I've got a first.
Thank you.
Got a second, all in favor? Any opposed? Okay, we've got item G,
All right.
is to consider approval of the addendum to DIR contract number, did I skip one? I'm sorry, F. Item F, to consider approval addendum to DIR contract number DIR CPO 5687 VMware license between Tarrant County Hospital District and Prospective Data Solutions.
Okay, this is our virtual machineware, or VMware is the name of the product that we use. It was bought by Broadcom about a year or so ago. Our current request is for $1,965,303.85. That is for a 5-year agreement. We do have a 30-day out on this agreement, so don't let the price shock you. We are actually in the process, because this was an increase in cost for us, we are in the process, we are going to be releasing an RFP soon for services to host our 1,100 virtual servers. And so we will be looking to move away from this vendor, but they would not do less than a 5-year agreement. We did get the 30-day outs, though, for the agreement.
Any further questions? Like to entertain a motion? Got a first and a second, all in favor? Any opposed? Okay, now item G is to consider approval of addendum to DIR contract number DIR CPO 5687, network infrastructure between Tarrant County Hospital District and General Data Tech LP 1372307.
This contract is for our system that does the traffic directing on our network. We have some critical shortfalls in our network right now about basically what it does is it provides every time a computer or medical device comes online, it assigns it an IP address, it creates a directory for the IP address, and it helps us monitor from connecting to unsafe environments. And so this contract for $537, $365.76 is, that's the purpose of it, is to strengthen some critical network infrastructure.
Why is it only 1 year?
It's putting it in place, DT. It's not a monitoring contract. It's actually putting it in place to do the monitoring. It's the implementation.
And no maintenance associated with it going forward?
There's no.
And this is for all the equipment coming into the hospital?
This is basically, we have a network right now, and we just need to monitor what's coming on, and we need to strengthen that monitoring and cataloging what's on the system.
It's an infrastructure.
Is this the switch that you're looking at, or is it software?
This is software. It's basically, it's looking at the DNS or the domain name system that we have. So it's contracting those, assigning the IP addresses, as well as cataloging them, and then also monitoring to make sure nothing's getting in. So it's not a firewall per se, but it's another preventative maintenance from us getting attacked.
But then, how do they keep up with the maintenance if there's no maintenance
So
associated?
there is maintenance, but there's not a fee on top of it for it. It's part of the package that we have. We
So
just
we-
have to implement it.
And then-
So it's something we already have.
And then the 15%?
We just have to upgrade.
The 15% just continue on the other
Right.
side? Okay.
Yep, sorry, DT.
Any further questions? Okay, with that, I'd like to entertain a motion. Got a first? Got a second? All in favor? Any opposed? Okay, thank you, Kim. Charlie? All right, on to item H is to consider approval of 1 exemption to bid and 2 supply agreement between Tarrant County Hospital District and Prolacta Bioscience.
Correct.
Charlie?
Good morning. This is a $750,000 contract, about $252,000 a year. It's an exemption to bid for human-based milk. It provides fortifiers for our premature infants in the NICU.
Any questions for Charlie? With that, I'd like to entertain a motion. I've got a first, second. All in favor? Any opposed? Okay. Item I is to consider approval of Baxter Healthcare Corporation contract between Tarrant County Hospital District and Baxter Healthcare Corporation.
This is an agreement, $6.3 million total cost. It's for IV tubing and accessories. It's a 5-year agreement awarded through our GPO Vizient. Again, provides IV solutions, which is our primary solution provider, as well as some IV tubing and accessories.
Okay, with no further questions, if I get a motion? First and second, all in favor? Any opposed?
This IV stuff is costing us, isn't it, between the tubing and
Okay, item J is to consider approval of interlogic agreement between Tarrant County Hospital District and Harris County Department of Education.
Correct. This is a little different. This is an interlocal agreement which requires board approval. It is Harris County Department of Education doing business as Choice Partners. It's essentially a cooperative, a GPO, pulling the purchasing power of all Texas entities. The majority of Texas entities are a member of this organization, including Tarrant County itself. So this will give us access to potential contracts that we may want to utilize to drive down purchasing pricing.
Do we also have these same agreements with like Dallas Parkland?
Essentially, this operates the Choice Partners for the state, so Parkland is also a member of Choice Partners as well. So this is how we would aggregate our volume. This is just the agency that does that for us.
Okay, I see. Thank you. Any further questions?
Are they potentially have better pricing than Vizient?
It depends. We typically tier our GPOs. Vizient is our primary GPO, but there are ancillary categories that Vizient doesn't have a lot of contracts or support for. You can imagine these contracts are running a lot of education facilities, so a lot of facilities or infrastructure type contracts that typically aren't part of a GPO contract. So we use this to supplement categories that GPOs might not have contracts for.
Okay, no further questions. If I could entertain a motion, please. I've got my first, got my second. All in favor? All right, any opposed? Okay. That takes us to item K it's also Charlie, is to consider approval of 1, exemption to bid, and 2, RPNT Acute Services Dialysis Services agreement between Tarrant County Hospital District and RPNT Acute Services.
Okay. RPNT Acute Services are dialysis services for our correctional health jail patients. It's a 3-year agreement. Total value is $1.3 million, roughly $420,000 a year. We estimate about 4% growth per year. And again, it's to provide a routine ambulatory dialysis service for our jail patients.
Okay, I'd like to entertain a motion.
Move approval.
Got a
for
first?
exemption and all.
Got a second? All in favor? Any opposed? Okay. Item L is to consider approval of purchase agreement between Tarrant County Hospital District and Morris and Dixon Co. Charlie.
Morris & Dixon is our pharmaceutical wholesaler. This is awarded through our GPO, Vizient. We actually did an RFP that this contract was awarded through years ago. The original $3 million, 3-year contract was taken to the board. This is renewal of the remaining 2-year options on that contract. The total contract cost is $252 million. We're asking for an additional $99 million for those 2-year additional option periods.
I've got no questions. I'd like to entertain a motion.
Move approval.
Okay, I've got my first, got my second. All in favor? Any opposed? Okay. Last item, Charlie. This is item M, is to consider approval of the amendment of agreement between Tarrant County Hospital District and Quest Diagnostic Clinical Laboratories, Inc.
Right, total cost for this is $2.1 million. This is a 5-year agreement. It is awarded through our GPO contract. Quest provides clinical lab testing services for the district. We have several lab testing, obviously in-house, but use ARUP, but Quest has a lot of low costs and particular specialty tests that we may utilize as well. So this covers pricing through that agreement, and it was negotiated pricing as well for these tests.
Okay, no further questions. I'd like to entertain a motion. Got a first?
Second.
Got a second? All in favor? Any opposed? Okay, thank you, Charlie.
Thank you.
All right, last item, Brian. Brian, after this last item, maybe just a 30-second minute update on the projects that we've got underway.
Sure.
Okay, great.
Good morning, everyone. So as a matter of fact, this morning we brought in our crawler crane for the central utility plant. May have seen some traffic signs out there. So Excavation is underway there. Obviously, most of you were here last week celebrating groundbreaking for the hospital. We will start excavation on that, I want to say within the next 6 to 8 weeks. Still securing some permits, so that's a little bit soft at the moment. We're actually drilling piers in the MOB, and we, as you noticed as well, probably, the crane is in place out there, so we are,
Oh, got a crane.
we are on schedule.
The MOB, can you describe that for those, I've got a couple new folks here?
The crane or the piers?
No, the MOB.
Sorry, I go way into the weeds quickly. So it's our medical outpatient building. That building will be 10 stories. The bottom 3 floors will be pharmacy, lab, outpatient surgery, and an imaging center. In the outpatient surgery, there's some endoscopy suites as well. And then the upper floors are all clinic space, different providers, different specialties. I'm going to get the number of exam rooms wrong, but it is a very densely populated building. There will be more exam rooms per square foot there in that building than any other building I've previously built. So it will be a very efficient producer on campus for us for outpatient services.
Thank you.
Sure.
All right.
Location of that.
That is, it is right, it's on the east side of the parking garage. So between Main Street and the parking garage, it doesn't look like it's big enough. It fits. We've measured multiple times to be sure. Pardon me?
Dorothy and I, at the groundbreaking, was trying to locate where the building.
Yeah, if you were at the groundbreaking and you looked at the big blue crane over by the parking garage, that blue crane is for that building.
When that goes up, it's gonna look, I mean, it's gonna make the garage look
Yeah.
not as big as it is, because it's gonna expand above it, so.
Okay, thank you, Brian. So on to item N is to consider approval of service order number 3 between Tarrant County Hospital District and Cavalis LLC.
Yes, presenting this morning, this is for $2,697,777 with Covalis, who is a medical equipment planner. They assess the needs of medical equipment in, this is for the hospital contract specifically, and coordinate design efforts with the engineers and the equipment manufacturers such as Philips, Siemens, GE, who might be providing some of the larger equipment. Counts what's useful life of current equipment and what we have to buy new. So they are an integral part of our design and build team going forward.
Okay, thank you. Any questions for Brian? That I'd like to entertain a motion. Got a first?
Second.
A second, all in favor? Any opposed? Okay.
Thank you.
I just want to make it clear to the board
Yes.
that when I talk about the B2G system, it's not an ERP, it's not a SAP, it's not an accounting system. This is a system that is more of a compliance. It's going to track when the primes get paid and when those businesses up under that prime, whether they're first tier, second tier, third tier, it's going to track their payments. I'm a small business with a project this size. I think we should have some systems in place to make sure that local and small businesses are set up to get paid and people are being held accountable for it. Especially if it exceeds 60, 90, sometimes 120 days. One of the other things that, Brian, I think we should start, change orders. Those things can take up to a year. You know, what is our procurement gonna look like for change orders? You know, most contractors come in with a lump sum number, but change orders may cost for them to go in and say, okay, what's your labor rate? What's your material cost? What's your equipment? Is any of that stuff gonna be in play? And I don't think it's fair for small businesses to get into these projects and this stuff is not worked out. I'm personally going through one right now with the K. Bailey Hutchins Convention Center. That's an absolute mess. So I don't think we should wait. You know, we got the crane going, we got things happening. These things should be put in place. So I'm not saying things because I want to get on people's nerves, but I'm saying it because it's a real problem that exists businesses that cannot finance these projects. They need to be prepared, they need to know how they're gonna get paid. We need to know, as JPS on the owner side, how does that flow, right? Who's gonna monitor each one of these systems? B2G is not gonna keep your major equipment. It's not gonna keep your MRI equipment, all your big major, that's not what it's for. It's for compliance, and it's for visibility, and it's for people like Colin when he's looking into the system, or when we're looking at it. We see where it's going and who's being paid. And, you know, I'm gonna stop here in a minute, but it was an issue the last round. There were contractors literally waiting for a couple of months to get paid. I know Dr. Duncan had to get involved with that. It should not be that. And I can't sit on a board or support something that I know that there has an issue. You know, I have to use my voice and I have to say something because I want to keep that in the forefront. Okay, so thank you.
Yeah, and also, I mean, I guess remind me, Dr. Duncan, at one point, there was a steering, or there still is a steering committee that was focused on these projects, is that right?
So that was really, the steering committee was a group made up of board members, county members, it was really set up to determine what was going to be in that master facility plan.
I see.
Yeah, did not get into the nuts and bolts
Into the
of.
details.
Yeah.
So, I mean, would it be possible to have a little bit more involvement? You know, to have Brian and bring Ramon and Jill and have a little bit more involvement on the construction component? I'm not saying every meeting, but a little bit more involvement moving forward so that we can better understand all these moving pieces from price escalation to, vendor procurement or, everything involved here. So I guess that would be my request, is to have a little bit more involvement, as this is, kind of the big focus here moving forward, so.
So I think that would be.
And I don't know if it would be like the steering committee, but kind of, similar to that. Maybe we don't need to have county folks involved, or welcome.
I was going to say, that may not be a bad
Right.
suggestion.
I mean,
just
they're
so that
certainly
they are
welcome.
aware, but,
Right.
but no, and first of all, I want you to know that I do hear you, and I appreciate your advocacy for the small businesses, so I don't want to minimize what you are suggesting. I think my frustration that you hear is often with, I thought we had this kind of decided on, so that was more my frustration from our side of it, so I apologize if it came across in that way. To your
Demetra, I hear
request,
you.
if we can
I hear you.
maybe,
We'll work on it.
yeah, if we can take that offline and figure out what that would look like.
Okay.
And make sure.
Absolutely.
That we're able to put that together, I'd be glad to take that on.
All right, thank you. Okay. With nothing else, I'd like to adjourn the meeting. Thank you.
Well, you took up the whole 2 hours.
There you go.
It's time for other meeting to start.
So like, it's at noon, is that right? Okay, all right, I'm actually, do you need me for a quorum?
I don't believe so.
Okay, because I was gonna meet with DT and Dr. Duncan
Okay.
on several items. But I gotta meet with Commissioner too, so anyways. If you need me,
You got a lot, yeah, no, I think we have,